Today we will be studying about skin, superficial fascia and deep fascia of the neck. The knowledge of skin, superficial fascia and deep fascia of the neck is extremely important. The lines of cleavage in the skin help to plan the direction of surgical incisions. The structures within the superficial fascia help in closing the surgical incisions and stop profuse bleeding. Deep fascia forms facial compartments and spaces in the neck. It also forms facial planes along with infection and can travel from one place to the other. Superficial veins in the neck are often examined to assess the state of health. Skin. Skin is the region of neck. Skin in the region of neck is thin and normally under tension. The direction of tension lies often correspond with wrinkle lines. The cleavage lines are disposed transversely around the neck. Therefore, surgical incision made along these lines, that is, transverse incision in the neck, heal with invisible scars. Cutaneous innervation. The cutaneous innervation of the neck is derived from C2, C3, C4 spinal segments. The first cervical nerve has no cutaneous branch and ventral rami of C5 to T1 from the brachial plexus to supply the upper limb. Skin above the C2 dermatome is supplied by trigeminal nerve and skin below C4 dermatome is supplied by spinal segment. The skin on the anterolateral aspect of the neck supplied by four cutaneous nerves derived from ventral rami of C2, C3, C4 spinal nerves. Skin on the posterior aspect of the neck is supplied by dorsal rami of C2, C3, C4 spinal nerves. So anterolateral aspect of the neck supplied by ventral rami of these and posterior dorsal rami of these. Superficial fascia. Superficial fascia of the neck consists of thin layer of loose areolar tissue and contains a thin sheet of muscle called platysma. In addition to platysma, it also contains cutaneous nerve, superficial lymph node, lymph vessels. Cutaneous nerves and veins lie deep to platysma. Amount of subcutaneous fat is more in children and women than men. Platysma. It is a thin quadrilateral broad sheet of muscle in the superficial fascia of the side of the neck. It ascends onto the face from front of the neck. Morphologically, it represents the remnant of Panniculus carnosus of animals. It develops from second pharyngeal arch. It covers the antero-inferior part of the posterior triangle of the superior part of anterior triangle of neck. It covers the antero-inferior part of posterior triangle and superior part of anterior triangle of neck. Okay. Origin platysma arises from skin and deep fascia covering upper part of pectoralis major and anterior part of deltoid muscle. Insertion after origin, the fibers sweep upwards and forwards superficial to clavicle and sternocleidomastoid. It crosses over lower part of posterior triangle and upper part of anterior triangle to reach the lower border of mandible, where anterior fibers decussate with the corresponding fibers of opposite side across the midline for about 2.5 centimeter below and behind the symphysis menti. Most of the fibers are inserted into lower border of the body of the mandible. Some posterior fibers pass superficial to angle of the mandible and masseter muscle and then turn medially to insert into the skin of angle of the mouth through risorius. Nerve supply. Platysma is supplied by cervical branch of facial nerve. Acting from above, platysma produces vertical ridges in the skin of the neck, realizing the pressure of the skin over the underlying veins and thus helps in venous return. It therefore serves and ease the pressure of tight collar. Acting from below, it helps to repress the mandible, draw the angle of the mouth downward and lateral as an expression of terror and horror. Clinical correlation. The surgeons, while closing an incision in the neck, suture platysma meticulously as a separate layer to prevent adhesion of the skin and subcutaneous tissue to deeper neck muscle, because such adhesions cause the overlying skin to move as the deeper muscle contract or relax, and the wound will heal with an ugly scar, which is cosmetically unacceptable. Since the superficial veins of the neck lie under the cover of the platysma, the retraction of divided platysma keeps the cut veins open. These veins are unable to retract due to their attachment to deep cervical fascia. However, if deep fascia is cut, veins retract and most of the bleeding stops. Cutaneous nerves of the neck. The skin of the back of the neck is supplied segmentally by cutaneous nerve derived from dorsal rami of C2, C3 and C4 spinal nerves. The cutaneous nerves of the back of the neck are described in this chapter. The skin of the front and side of the neck on each side is supplied by four cutaneous nerves derived from ventral rami of C2 to C4 spinal nerves through branches of cervical plexus. They are named as follows: lesser occipital nerve, greater auricular nerve C2 C3, transverse cervical nerve C2 C3, supraclavicular nerve C3 C4. Superficial veins of the neck. There are two superficial veins of the neck. These are external jugular and anterior jugular. External jugular begins just below the angle of the mandible by the union of posterior division of retromandibular bone and posterior auricular vein. It then runs almost vertically downwards across the sternocleidomastoid under the cover of platysma to pierce the deep cervical fascia in the anterior inferior angle of the posterior triangle, about 2 cm above the clavicle along the posterior border of the sternocleidomastoid, and enters the supraclavicular space. After passing through this space, it terminates in the subclavian vein. External jugular vein varies considerably in its size and course. It becomes visible in old age, particularly when the individual holds his breath or blows his cheek with mouth closed, as it impedes the venous return to right side of the heart and distends the vein. Surface anatomy. The external jugular vein can be marked on the surface by line extending downward and backward from angle of mandible to middle of the clavicle. Its tributaries are as follows: posterior auricular vein, retromandibular vein. These are formative tributaries. Next, posterior external jugular vein, oblique jugular vein, transverse cervical vein, suprascapular, anterior jugular vein. These are terminal tributaries. Next, external jugular vein, a little below the midpoint of posterior border of the muscle. The oblique jugular vein communicates with the internal jugular vein in the upper part of the neck. The suprascapular, transverse cervical and anterior jugular vein join the external jugular vein in the posterior angle. There are two pairs of valves in the lumen of the external jugular vein, one at its termination into the subclavian vein and other about 4 cm above the clavicle. These valves, however, do not prevent regurgitation of the blood. The wall of the external jugular vein is adherent to deep fascia where it pierces the deep fascia. Therefore, if external jugular vein is cut at the side, its wall cannot collapse. Consequently, air is sucked into the lumen due to negative intrathoracic pressure during inspiration, leading to venous air embolism, which may cause death subsequently. The external jugular vein is occasionally used for central venous cannulation, but due to its variable size and presence of valves, it is often difficult to manipulate the cannula through the lower part of the vein. The right external jugular vein being the most direct line with the superior vena cava, it is the most commonly used. External jugular vein is often examined by clinicals, assess the venous pressure in the right atrium. Normally, it's in recumbent position. The lower one-third of the vein becomes filled with blood, but it collapses on reclining at 45-degree angle. However, if it remains full even when the patient reclines at 45-degree angle, it suggests increased right atrial pressure, often seen in congestive cardiac failure. Anterior jugular vein, it begins below the chin and the submental region by the union of small unnamed veins from the chin. Descends in superficial fascia from 1 cm lateral to midline. At about 2.5 cm above suprasternal notch, it pierces the investing layer of deep cervical fascia to enter suprasternal space of bones. When it turns sharply laterally and passes deep to sternocleidomastoid and terminates in the external jugular vein. In the suprasternal space, the anterior jugular vein is united across the midline to its fellow of opposite side by transverse venous channel called jugular venous arc. Superficial lymph nodes and lymph vessels. The superficial cervical lymph nodes are situated around the junction of head with neck. They drain all the superficial structures and some deep structures of the head. Most of the afferent lymph vessels from these lymph nodes pass to deep cervical lymph nodes arranged along the internal jugular vein. A few scattered superficial nodes are found along the external and anterior jugular vein. They also turn into deep cervical lymph nodes. The superficial cervical lymph nodes situated around the junction of head and neck to form pericervical and cervical collar. They are arranged into following groups: submental nodes, submandibular nodes, superficial parotid nodes, retroauricular nodes, occipital nodes. Submental nodes, 3 or 4 in number. The submental nodes lie on mylohyoid muscle below the symphysis mentis and receive the lymph from the tip of the tongue, lower lip and chin. Submandibular nodes, about half a dozen in number, lie on the surface of the submandibular gland and receive the lymph from the face, cheek, nose, upper lip, gums and tongues. Parotid nodes, the preauricular nodes lie superficial to parotid fascia and drain the lymph from scalp, auricle, eyelids and cheeks. Mastoid nodes, 1 or 2 in number. The retroauricular nodes lie on the mastoid process and drain the lymph from the scalp and auricle. Occipital nodes, 1 or 2 in number. The occipital nodes lie on trapezius about 2.5 cm inferior lateral to inion and drain the lymph from the scalp. They are table for being palpable in German measles. These groups form a kind of ring of lymph nodes at the junction of the head and neck and may appropriately be called necklace of lymph nodes at the craniocervical junction. The lymph nodes of pericervical collar are clinically palpable only when enlarged. Deep cervical fascia, fascia colli. It is important in my question. The deep cervical fascia of the neck is clinically very important as it forms various facial spaces of the neck. It also provides capsules to the glands and invests the muscles in the region. In addition, it forms protective sheath around neurovascular structure. The layer of deep cervical fascia form facial planes to redirect the spread of infection or pus in the neck. The deep cervical fascia of the neck consists of three layers from outside to inwards. These are investing layer of deep cervical fascia, pretracheal, prevertebral. This is from outside to inwards. The spaces among the structures of the neck are filled with loose areolar tissue. The structures of the neck are mostly designated to move up and down. The layers of deep cervical fascia are no more than a laminar condensation of loose areolar tissue produced by movement of these structures. These laminar condensations take different names in different regions and are continuous with each other either directly or indirectly through loose areolar tissue. The loose areolar tissue forms facial sheets or lamina in the same way as unwoven cotton forms sheets of cloth after spinning. These lamellae ensheath muscles and other moving structures. This permits movement between the sheets and movement of structures within it. Investing fascia, this layer encircles the neck like a collar deep to platysma and superficial fascia. In doing so, it encloses the sternocleidomastoid and trapezius, the two last superficial muscles on either side of the neck. Attachment, superiorly it is attached to external occipital protuberance, superior knuckle line, mastroprocess and lower border of mandible from behind forwards. Inferiorly, it is attached to spinocerebellar acromion process, upper aspect of clavicular, jugular notch of manubrium sternum from behind forwards. Anteriorly across the midline, it becomes continuous with its counterpart of the other side. In anterior midline, it is attached to symphysis menti, hyoid bone, jugular notch from above downwards. Posteriorly is